Louder. Dr. Cheema is here again today, and he's going to be doing an in-service for us on COPD. There is a clipboard going around for you to sign in, so please do so. And let's give Dr. Cheema a warm welcome. That's right here.
We have a microphone coming. Need it. So then he doesn't have to yell. You guys, you know what? Let's all move in closer. Let's everybody move in closer.
There's chairs, right?
I thought that one had wheels.
Are you gonna be working?
Yeah, just don't block the middle. I got the camera right here.
Okay.
I was with a patient with it.
Carol, you want to chair in?
Some people work on it while they're doing.
Yeah, that's. Hey, why are you moving my? Why are you taking my spot?
The lamp there, I'll slide you over.
You can't sit in the middle.
If I'm below that, I think I can.
Well, if you're gonna be below it, you can. Yeah, sure.
Try to be slick. 3 strikes.
About time.
Same doctor we did just last time.
All right. Can everybody hear me? Otherwise, anyway, I'm really grateful that Debbie is handling the computer. She'll be helping me out with the slides a little bit. So I haven't made too many slides. I'll try to keep it short and sweet, and try to summarize, the basics, anatomy or the basic physiology, so that at least everybody gets an understanding of what COPD is. I'm sure you guys have heard that term many times on the TV or from commercials or the drug reps, but a lot of people sometimes don't understand what exactly it is. Afterwards, I'll go through some tips how knowledge of COPD could be useful to you guys per se in regard to the nursing homes, the hospitalizations, so that hopefully you can get it.
It's the door people. They have a slide.
So hopefully you guys can become knowledgeable about the subject. So this is just a basic picture. Can everybody hear me reasonably?
Not really.
Not really?
I can.
Well, come closer,
I'm pretty close.
You guys can all hear.
So this is just a picture of trachea tube, which is right here, and it's connected on the top to your mouth. People usually, when you open your mouth and breathe, the air goes into the trachea, comes down right up to here, it splits into 2 pieces called bronchus, and then every bronchus, like a tree, divides into smaller tubes. And then at the end of the bronchus, or at the end of these tubes, there are tiny sacs, which are called alveoli. Each lung is divided into different lobes. You have 2 portions on the left lung, and then you have 3 portions on the right-hand side. This is kind of a picture. Yeah, let's make it a little bigger. So this is a picture of the lungs basically sitting inside the chest wall, located on the top. There's a big muscle at the bottom, which is called the diaphragm, which usually lungs down.
Karaoke.
Everybody can hear me now?
Yes, sir.
Okay. So the diaphragm is a very important muscle which helps people breathe. Most of the time when we are not exerting ourselves, sitting down comfortably like most of you guys are, the major muscle which is responsible for breathing is your diaphragm. Let's move on to the order two. So what's the job of the lungs? Can anybody tell me? That's it. So basically, the human body is just like a car engine, or it uses fuel, it produces energy, and then it produces exhaust. So the lungs are responsible for delivering the oxygen through the blood to the different parts of the body. And lungs are also responsible at the same time for helping the body get rid of the exhaust gas, which is the carbon dioxide. Now, where does this whole thing happen? Where does this take place? This usually takes place in sacs, which are called alveoli. So alveoli are like tiny sacs connected to the small tubes through which the air came into them. And then so let's go to the normal one. So once the air is inside the alveoli, it will diffuse or move across the membranes into the blood vessels. So the oxygen will go this way, and the carbon dioxide from the blood will go back in. And of course, when you breathe out, this air will come out. So there is. So when somebody says a COPD, there's actually a spectrum of diseases which make COPD. And it's usually a combination of 3 diseases. One of them is chronic bronchitis, the other one is emphysema, and then to a minor extent, there is asthma. So these 3 diseases in combination usually lead to a term called COPD. Now we all know what's asthma. Usually, kids are getting it. Of course, it can move into the adulthood and become part of the COPD. But there's 2 major diseases which we need to be able to differentiate between. One is the emphysema, and the other one is chronic bronchitis. Well, too much. So now you got normal lungs. Now this tube here is the bronchiole. Bronchiole was the tube. Remember I explained to you? It's one of these tubes inside the lungs. There's a picture of a normal tube. So now what happens is in people who have chronic bronchitis, they usually have inflammation in the lining of this tube. And due to the long-standing inflammation, they will start developing a lot of mucus. The walls of the tube will get thickened. And this leads to a person with chronic bronchitis most of the time to chronic cough. So one of the clinical definitions of chronic bronchitis is if a person is coughing 3 months in a year when bringing up phlegm, and he does that for 2 years, that itself is the definition of chronic bronchitis. Now the difference between the bronchitis and emphysema, the chronic bronchitis is happening at the level of the bronchioles, which is the tubes. The emphysema, on the other hand, happens at the level of the alveoli. The alveoli are the tips at the top of the tubes. So what happens in emphysema is, if this is the normal structure of an alveoli, inside the alveoli there's a lot of elastic tissue which kind of holds the alveoli together. In people with emphysema, usually this inside tissue gets destroyed, and you have these loopy, dilated alveoli. So they fail to do their job, which is the transfer of the oxygen across the membrane. Excuse me. So 6.3% of US population has COPD. So what causes COPD? What's that? Smoking. So in developed countries, which is like United States, one of the major causes of smoking is, let's not put it, no, it's not stress. It's not stress. Yeah, stress can lead to smoking, of course, in some people, but it's basically cigarette smoke. So long-term exposure to the cigarette smoke will usually lead to either one of these diseases, chronic bronchitis or emphysema. And we don't know why somebody gets that versus the other. I don't think we've been able to figure that out yet. Does every smoker get COPD? And the answer is no. Only about 30% of people who smoke, they're going to get COPD. Now, I don't want you to get encouraged that way, because the problem is 70% would not get COPD even if they smoke. Of course, they'll get other diseases. You know, they can get lung cancer still without the COPD. You can get heart disease. You can get strokes. You can get tons of other things. So the problem is you can't predict who will get it and who will not get it. So it's a little more complicated than just cigarette smoking, but definitely cigarette smoking has got a strong role to play in COPD. And what I really want to tell you is, you know, talking about this, you know, if some of you guys are smoking, you know, it's important that I kind of bring this up to you guys. I have been in practice for approximately 20 years, and you know, as a medical student, I was in the medical school for another 5. So around 25 years, I've been seeing patients for. And what I've seen is, you know, people who are developing COPD from smoking, initially what happens to them is, I get a cold every 3 years. Most of the people, they will get a cold every year. And of course, some lucky ones, they get cold every 10 years. So people who are smoking, they will usually start catching more colds. So that's how it will start off in the 40s, you know, 30s and 40s. Also, you will notice that the colds that these people get, a person would recover in 3-4 days from a simple cold. But the people who smoke and who have early COPD, they don't recover that fast. It usually takes them a week. You know, we treat these people with antibiotics for a simple bronchitis. A normal person would recover. A person who is a smoker, he will require another course of antibiotics. They, you know, they will come back to your office and say, Doc, it hasn't really gone away completely yet. So you will. So we start noticing that younger people who are developing COPD start off by having stronger colds, frequent sinus infections, and then longer colds and longer infections and harder to treat. So that's earlier on. And then what happens is once these people, they get into about, you know, 50s and their 60s maybe, then what would happen is once in a while, they will get a stronger cold which turns into a bronchitis, and somehow they can't breathe too well and they end up getting to the hospital. So you will start noticing every couple of years, they now end up in the hospital. They stay there, they get IV steroids, they get IV antibiotics, and they get discharged. Of course, some of them don't smoke, and the ones who don't smoke, they will change the course of the disease, and I'll explain to you how. Now, people who continue smoking and, you know, continue having the disease later on in the 60s and 70s, they will at least be getting admitted once or twice in the hospital. And of course, if they make it to later stages, you will start noticing that some of them, they become oxygen dependent. They get a cold almost every 3 months. Then they go to the hospital every couple of months. Their hospitalizations are longer, they're prolonged. And literally, I've seen some of these people, they are living in the hospital and nursing homes. Not that there's anything bad with the nursing home, but they literally are living in the nursing homes and the hospitals for the rest of a couple of years or 1 year of their life. So you know, all that from cigarette smoke. rarely you will see somebody, I think there's a very small percentage of people who will develop COPD, maybe 1% or 2% of people who will have COPD, who never smoked. So, but most of them, 90%, 98% of them, they will always have a strong history. So that is true, that if you're a smoker, you may not develop COPD. You know, there's a 30% chance you will develop COPD. But on the other hand, if you have COPD, there's a 99% chance that you were a smoker, or you were exposed to some type of fumes or smoke in the past. Now, some of us, we were unlucky, maybe not me, but you know, some of the older folks, their parents were smoking a lot. So, you know, there were two parents smoking like chimney in the house, and you know, that got them quite a lot of exposure to the smoke. Some of us who were unfortunate have jobs which were exposing us to the smoke. You know, car mechanics, they're kind of in the garages, or people working in the factories in the older times. And a lot of people got COPD because of that. So anyway, what are the early signs of COPD? How do you figure it out? Of course, it is usually a history of smoking for 10, 20, 30 years. The age of the person, most of the time is above 40 when they will start developing this condition. Shortness of breath with exertion. They will tell you that, you know, I just can't do as much as I was able to do before. I get short of breath exercising, I should get short of breath trying to do my chores. If a person has chronic bronchitis as part of the COPD, they will also tell you they have cough. And something called the smoker's cough. Smoker's cough means they will wake up in the morning, and what has happened is, I showed you the picture. Let's go to this one. Yeah. So as I've shown you the picture, a lot of sticky mucus, or in street language, gunk, or whatever you want to call it, is accumulated in their bronchioles. And what's happening is now, the lungs don't like that, so they make you cough. They make you cough so that they can get rid of this junk. So a smoker will wake up in the morning and have, you know, a few episodes, 5-10 minutes of nice cough, and then he will bring up tons of phlegm, and then his day will go by. Now that's what happens in early stages. In late stages, they will cough during the daytime too. Because of this condition, you can see that the air is moving across a smaller diameter. So now the air, when it moves, it will move faster. So when it moves faster, you will get the wheezing sound. So a lot of these people with COPD, they will have a wheezing sound. Sometimes you can hear it without the stethoscope. But if you definitely put your stethoscope, people with chronic bronchitis, they will have wheezing. Wheezing is a whistling sound that you hear when you put the stethoscope on somebody's back. So what happens with emphysema, if you put a stethoscope, I can put my scope on patients' back, and I can tell them they have emphysema. You know, even they haven't told me that they are smokers. And the way you can tell that is, remember the tips of the lungs? The thing which is in connection with the lung at the tip is the alveoli, the sacs. Now when the person breathes, the sound of the breath gets transmitted across the wall, and that's what you hear outside. So now if the person has got emphysema, he has a lot of destruction of the solid tissue there. And we all know the air travels faster and effectively in the solids compared to the air itself. So if a person has a structure where all these alveoli have been damaged, he has less solid tissue there. So when you put your stethoscope, you can't hear anything. You know, they take a nice deep breath and there is no sound. And that usually means that they have some type of emphysema in the right clinical setting. So as I was saying, they will get shortness of breath. People with chronic bronchitis, they're usually heavier. They will have bluish lips sometimes, of course in late stages. If you look at their fingers, they will have some blueness or a bluish hue to their fingertips. People with emphysema, they're usually reddish. So they will appear more, they'll have a reddish face, and they're usually underweight, or they are usually not as heavy. But again, the thing is, you don't get, sometimes you'll get a typical emphysema patient, sometimes you'll get a typical chronic bronchitis patient. but most of the people, they lie in between. They have a component of both, emphysema and bronchitis. So now COPD is associated with comorbidities, and the two common comorbidities, comorbidity meaning that another disease condition associated with it, or that goes kind of commonly with it. One of them is congestive heart failure, and the other one is coronary artery disease. So you will see there will be less people, or there will be a bunch of people who will have all these three things together, just to complicate things a little. Most of these treatments of the COPD, the first treatment is going to be quit smoking. Because if you do not quit smoking, or the patient doesn't quit smoking, the chances are he's going to keep on irritating his lungs and keep on damaging his lungs over a period of time. So first of all, you got to stop the smoking. One other thing I wanted to point out is this device here. Can you click that? I'm not sure if you've seen this device here. So this is a chamber or a spacer device, and what it does is it connects to the inhaler. So back in the old days, they only used to have inhalers which were pressurized. Nowadays, of course, we've seen those discs and we've seen powdered inhalers. So back in school one time, there was a patient we had, and he would always have, asthma, which wouldn't get better. And we just asked him, how do you use this inhaler? And actually, the guy was just taking it out and spraying it on himself. So this is what we don't realize. So a lot of times we don't realize, and this is not it. Every time, almost, for the first time or for the second time, the new patients who start using inhalers, I usually ask them, here's an inhaler, we pull up a sample, and say, I usually show them how to use it once. And then I ask them to repeat it. So a lot of people in the country, they're not using the inhalers properly because what they do is they will spray it and then breathe afterwards. So now what's happening is the drug is actually just sitting in their mouth and hasn't even gone down into the lungs. And it does require a little bit of coordination. Some people just can't do it. I have had some people, you will explain them, you will ask them to show it to you, you just can't do it because they can't coordinate the movement of the breath with pressing your hand. That just doesn't come to them naturally. Not their fault, we all have natural reflexes, so they can't. They will always either hold the breath and then click it or something. So what happens is, if your patients here are not using the inhalers properly, that means they're really not getting the medication in. So one of the jobs should be every patient that you see next time using an inhaler, you have to ask them, can you show me how to do it? Just take a minute to see how are they really doing it. Now once in a while, if you run into a patient who is unable to coordinate the movement, and this is for children usually, but we use it for adults too. So what they do is they have a spacer device, and what happens here is the person just compresses the inhaler 2 times, the drug goes into this chamber, and then you just breathe through it. Now back home we used to tell people if you have a Coke bottle, one of the Coke bottles, you can just make a hole at the bottom, put the inhaler there, because these devices can be expensive. Sometimes people can't afford them. So they would just have Coke bottles, and you can make a spacer device out of that. You don't have to do it here, but just out of just for the interest, because kids cannot coordinate. So let's get rid of that. So let's just put this one here. That's not quite coming right, but I just wanted to give you an idea. There's just tons and tons of medications available for the COPD. So there is a basic category of the medications for the COPD. The earliest ones which came for the treatment, they are called beta agonists. And what they have is, they have a drug in them which causes the muscles in the tubes, the bronchioles, which are the tubes inside the lungs, that medication causes the muscles to relax. So as I showed you that picture where there was a tiny hole because the mucus had plugged it up, if you were to give them a medication which relaxes the muscles in the tubes, you are likely to open it up. So they rely on that particular technology. Now they come in two different varieties. They come in short-acting ones and the long-acting ones. So important for you guys to know. So if somebody's having an attack of COPD exacerbation, let me go back to that. So most of the people with COPD, they have symptoms as a baseline. So on their daily living, daily activities, they will have some type of shortness of breath, a little bit of cough. But then these people, once in a while, they go into something called exacerbations. And exacerbation means the whole condition that they have got multiplied all of a sudden. So if they were a little short of breath, now all of a sudden they become very short of breath. Now why does that happen? It usually will happen from an infection. So it will happen either they started smoking again, they irritated their lungs all of a sudden, or it will happen because they got a cold. So it's a simple cold which will cause an exacerbation of COPD. COPD exacerbations are the ones which are costing a lot of money and bring a lot of negative outcome. Just tons and tons of expense and tons of hospital admissions because of the COPD exacerbations. They can be prevented, by the way. And I guess that's what I want to talk about. So once you have an exacerbation of COPD, if you give them the beta agonist, those medications that I discussed earlier, you cannot give them the long-acting ones. Because if you give them the long-acting ones, they will start working after 3-4 hours. So you're not going to get any result out of them. So what you do is you want to give them the ones which are short-acting ones. The short-acting ones, they start working very fast. So what's an example of a fast-acting beta agonist? Albuterol. So the therapist, I guess they know that's something that you would want to give to a patient who is having an exacerbation. How often can they be given? Usually 4 times a day, or actually even up to every 4 hours. They can be given how? They can be given through an inhaler, or they can be given through a nebulizer. If a patient has an exacerbation and is in your facility, and you want to do the best for them, you guys should have nebulizers. Sure you do those. Yeah. So that drug can be given through the nebulizers. The other drug that they also use are, so an example of that would be Atrovent. You would see the pharmacist, they will mix the albuterol with the Atrovent. So Atrovent is a muscarinic acting medication, and what it really does is, the tube which I showed you, remember the beta agonist, they're dilating the tubes. So now you have more volume for the air to go through. Those muscarinic or Atrovent type of medication, what they are doing is, they are decreasing the secretions inside the tubes. Because remember I showed you there was a lot of mucus, which was plugging these tubes up. So a long-acting medication, like Atrovent, would be Spiriva. So most of the patients who have COPD, usually enough that they land in this facility, they should be taking some type of medication which decreases the secretions in the tubes. So what's the long-acting one? Spiriva, that's an inhaler. The short-acting one would be Atrovent. So normally you would mix the mixture of Atrovent along with the albuterol and usually give them a breathing treatment. Since I said most of these exacerbations are caused by infections, it's always a good idea to treat these patients with a COPD exacerbation with some type of antibiotics. The one that I have been using, since I came here, is azithromycin. It has always turned out to be one of the best ones. I still haven't had to change it. I still use the same medication. I think it works better than any other antibiotic. We're talking about the one right now. And I think you guys have the ability to even give them Rocephin here, don't you? So the standard of care, even in the hospital nowadays, is to combine the azithromycin antibiotic along with the Rocephin, because that will even take care of any underlying pneumonias. So if you do make if a diagnosis of COPD is made, that combination of antibiotic would be excellent. If it's a minor exacerbation, like in my outpatient practice, we just use the azithromycin. We don't usually give them shots, unless I know them from before and I know they're going to end up in a hospital, then we give them shots of Rocephin, and we are able to decrease the, so for our own clinical practice, we have decreased the two major admissions to the hospital. One is the CHF, and the other one is COPD. These are the two easily preventable admissions to the hospital. We used to have a lot of these before when we weren't paying enough attention, but lately we've been paying attention and have been able to cut admissions down for these two diagnoses. So how do you want to prevent a exacerbation? How do you want to prevent? Well, one of the things which causes a lot of trouble every year is flu. So if you guys have flu shots, of course all the patients should get the flu shot. And let me just talk about the flu shot a little bit, because there's a lot of misconception, and there's a lot of medical people who are in this business and they don't get flu shots. And I'm sure there's several sitting in this room. So what's the reason they don't want to get a flu shot is because they say, I get flu from getting the flu shot. Now you have to understand what flu is. We're not talking about a cold. We're talking about influenza. And the way influenza virus affects you is it will affect the lungs and usually causes pneumonia. So it's not just a sore throat, a runny nose. It will cause usually a pneumonia. That's how people die from flu. So the way the scientists make the flu shot is the one that we are injecting into people, it's killed the virus. So it's dead. So it's not alive. It doesn't have the ability to reproduce inside your body once it's given to you. But what is it supposed to do? So the flu shot, once you get it, it's a dead virus. And once your body gets it, your body thinks you got affected by the real flu. So what does it do? It makes antibodies, or it improves its defenses so that that virus cannot affect you again. See, that's why we see everybody who has been vaccinated against polio can't get the polio. And we used to see a lot of polio, 50 years ago, 60 years ago. And why is that? Because everybody who got vaccinated against polio, their body is aware of that virus now. So as soon as the polio virus in the environment comes and attacks them, the body already is ready for it. It's just like, in a war, if somebody already knows what the enemy is going to be doing, and you're ready for it, there's a better chance you're going to be able to win it. So that's exactly how it works. Now what happens is, most of us, we get the flu shot, we don't get any reaction from it, nothing bad happens. But then once in a while, somebody's body gets a little more excited, and it creates a stronger reaction to the virus, to the dead virus. Remember, it's a dead virus. So what happens to them is they get a fever, or they feel like they got the flu, but they didn't get the real flu. They just got a feeling that they got the flu. They got a little bit of fever, but what it is its body's reaction to the dead virus. So a lot of people, they will get that reaction, then they go around in the community and they'll tell everybody, I got flu from the flu shot, and that gives it a bad, reputation. So I've been getting shots myself since I came here in 2002, and I've gotten sick a couple of times. One of those, because every time it's a different flu shot, it's a different virus. These viruses, they usually come from animals. So, they're always in the community. They're in the pigs, birds, rats, a lot of animals, cats, whatever it is. So the scientists, they have a job to predict which one of these viruses are likely to cause a problem in humans this year. And then they have to come up with a vaccine, or they have to come up with the viruses, then mix them. Of course, they kill them, they breed them, kill them, and then we inject them into humans. So, but again, as I said, the dead viruses, you can't get the flu from it. Now, if a person gets consistently sick every time they get the shot, they probably don't need to take it. If the sickness is Yeah, but just hearing the stories or you know, it's not a good enough reason. So one thing you can take out of this talk is, you know, everybody should be getting a flu shot. So that's how you prevent COPD exacerbations, by preventing viruses and preventing flus. So based upon in this setting, how would you guys be able to pick something up if somebody's having a COPD exacerbation? So the way we tell our patient, yeah, go ahead.
The question there is like, I know when we're looking at this COPD, they can't breathe. Everybody always wants to give them oxygen, but we can't give them too much oxygen. What can we do to psychologically make them more comfortable?
Good. So one of the standard treatments for COPD is oxygen. So I would not hesitate in giving oxygen to somebody who is awake, alert, and is hypoxic.
How high?
High, 5, 6 liters, whatever you have to give them temporarily at the time. So there is never a problem. I have myself opened them up all the way. You know, I think it goes to 15 liters or something like that. I don't even remember now. But yeah, 15. So I've even done that. So that will never get you into trouble. There's a very rare type of there's a very rare type of people that will sometimes, oxygen is the only drive that they have to breathe. And if you're giving them oxygen, you could cut the drive down. But you see, that's not going to happen like a click of a computer. So I'm assuming a person that you're giving full oxygen to, somebody will be watching them. Somebody will be with them. You know, you'll be watching them every half an hour or 15 minutes. So it's not going to be like they're going to just go off on you immediately. So the treatment would be give them as much oxygen as you want. You will not run into any trouble. But usually anything more than 6-7 liters is useless. So if you go up to 6 liters or so, that should be fine. But then those people just need to be monitored. Now, of course, if they become sleepy or they're becoming drowsy while that is happening, that's the kind of person who should be in the hospital. That is not somebody you should be handling here. The other thing, of course, all the patients with COPD diagnosis, they should have had a pneumonia shot, because the pneumonia shot is also a dead capsule. It's not a real bug. So every patient with COPD should have had a pneumonia. Pneumonia shot usually doesn't cause too much trouble. Most of the people will not get a flu-like symptom from it. You can get a swollen arm, a red arm, which ice will take care of that, or a little bit of Motrin will take care of that. So people should have had that. In a nursing home setting, if you are seeing a person who has a diagnosis of COPD, the question that you would want to ask that patient regarding the COPD is, when were you admitted to the hospital last time with COPD? So supposing you guys get a hip replacement or a knee replacement, and it's listed that the patient has COPD. So you would want to know, have they been admitted to the hospital recently or a few times in the past couple of years? If they tell you, yeah, I was admitted with COPD, you know, I get admitted every year, and that's a high-risk patient for you. Because if he gets an exacerbation, you'll have to send him back to the hospital. So that's a person who should be using all his inhalers. So what are the inhalers I told you? Well, long-acting beta agonists, some medication like Atrovent, which would be Spiriva. Also, the other medications which have become very popular nowadays for prevention of COPD and improvement in the symptoms of COPD are inhaled steroids. And I think the commonest one which is used in the country is Advair, which is very, and that's the one I want you to stick to. And the reason for that is because it's becoming generic, I think next month, or in a couple of months. So that's the first inhaled steroids which will become generic. So you want people to be taking generic medications and not just the unnecessarily expensive ones. And it does a job exactly the same as any other inhaler. So these people should be on inhaled steroids. They should be on some type of long-acting beta agonist. Now, if you guys are using Advair, there's a beta agonist in it already. And then, of course, Spiriva would be another medication that most of these people would be using. So the oxygen is the only medication which has been known to improve survival in patients with COPD. None other medication, and of course quitting the smoking, but that's not a medication, that's a behavior. So as far as the medication is concerned, if somebody asks you if there's any medication which will improve these people's, how long they live, it's only oxygen. The rest of the medications, the inhalers and all that, they will help you live better. They will help to decrease the exacerbations, but overall they're not going to make a difference in how long you live. So what would be the difference between a person who is short of breath from COPD versus CHF? And of course the difference would be the people with COPD exacerbation will have more cough, usually. They will be having increased sputum production, more than what they regularly do. It would not make a difference to that person if he's lying down versus if he's standing up or sitting up. People with CHF, on the other hand, because remember the pathology is different. The pathology is in CHF is the fluid is being retained inside your lungs. So what's happening is those alveoli, those sacs that I showed you, now there's fluid around them. So now the oxygen cannot move across because there's too much fluid there. So of course the fluid will change if you change. You know, if you're sitting up, the fluid will be at the bottom, which means the top part of your lung will be open for the oxygenation. So these people, they will tell you, with the CHF, they will tell you, I feel a lot better when I'm sitting up. Don't lie me down. If I'm lying down, I get short of breath. Also, people with CHF usually will have gained some fluid sometime, which means they would have gained some weight. So we were just discussing that with the nurses, that how to keep a track of the CHF patient is to make sure that they're being weighed on a daily basis. Patients with usually pure CHF will not have cough. They will usually be without the cough. They can have some cough, but not usually. And of course, if a person with short of breath and they're having fever along with it, that means they definitely have some type of infection. Anyway, any questions?
What about steroid use with our COPDers?
So that's highly encouraged. It's considered the standard of care. So what happens is if a person goes to the hospital, as a matter of fact, this is a Medicare criteria now for the doctors and for the hospitals too. And you taking care of, and the admitting diagnosis of COPD, and the person does not get discharged on the steroids, that's considered a DING, or a negative or bad practice. So every patient with a COPD exacerbation, the best way to treat them, what's the difference between hospital and outpatient COPD treatment? The difference, one of the biggest differences is they give you IV steroids in the hospital. They're able to do that every 6 hours. And most of the commonly used drug would be solomedrol. They usually use anywhere from 40 to 60 milligrams of that every 6 hours. That's one of the most effective ways to get the inflammation in your bronchioles under control.
Is that not something we would do here in prevention?
You should be able to. You should be able to do it. We in the office practices are unable to give IV steroids because we can't keep the patients in the office all day. We give them IM steroids. Sometimes we even give them IV steroids, but we give them on a daily basis. We can't do it, you know, every 6 hours. You guys should be able to do it. Yeah, you should be able to do it, and they don't have to be given for a long period of time. Nobody gains weight from steroids if you use them for a few days. That's a misconception. That only happens if you do that over a long period of time. And then most of these patients, you want to switch them over, you know, within a few days to oral steroid. But that will definitely prevent them from getting admitted to the hospital, because that's the only other thing they're going to do down there, is give them IV steroids. And of course the IV antibiotics, nebulizers, maintenance inhalers. There are some other fancy drugs out there too. One is very old one, which I've used on some of my COPD patients who keep on going back to the hospital despite whatever I do, is theophylline. So that's a good